I'd like to ask Professor Gamela Nasr for her presentation. Heart Failure Dialogue, Orchestra in Heart Failure Management. Please.
Thank you very much. الحقيقة أنا سعيدة جدا إن أنا بشارك في مؤتمر الأستاذة الدكتورة إيناس شلتوت و I do have the honor to share. الحقيقة إحنا بنتكلم عن Heart Failure Dialogue. I want to thank you, Sanofi, for having this marvelous forum. I'm talking about the Heart Failure Dialogue. How often do we see these patients in our daily life? الحقيقة the heart failure patient is the end stage of any heart disease, as we know. Of course, that we can see that the prevalence is 2% of the population. The incidence is very high all over the world. The growth is increasing because we see more patients, aged population, and so on. So it is the ugly face of heart failure. When we are talking about heart failure, we do have number of patients increasing. The mortality, again, is increasing. There is definitely an economic burden for hospitalized patients. Definitely, we do have patients who are having more than 3 comorbidities in heart failure patients. Very seldom to see patients having only one risk factor. Maybe there is the quality of life, which is really a big problem. Quality of life you have, of course, seen a patient with heart failure. Did you recognize how the patient is not able to do his daily life? Maybe you can see that 76% of the patients struggle to perform their daily activities. And 63% of them have symptoms that are consistent with depression. This is the typical picture of a heart failure patient. He's usually is not able to do his daily activity. He's not very depressed, and as we can see, rehospitalization is a really threat because you will see that these patients are rehospitalized very frequently. It is the #1 cause of rehospitalization all over the world. And of course, if I know that I am in heart failure, I will know that I will die within 5 years. So this is 50% of the patients die within 1 year. The burden is very huge. It is the leading cause of hospitalization, affecting more than 64 million people worldwide. So definitely it is a big problem. Of course, we see that definitely we do have, in Egypt, the patients with heart failure have many comorbidities. 40% are diabetic, hypertensive, obese, and smokers. It's very rare to see a heart failure patient with only one risk factor. It's usually having more than 3 risk factors. And this was seen in the study in the Egyptian for the heart failure patients. So heart failure definition. Heart failure is an abnormality of cardiac structure and function. Of course, it's a syndrome. It is not, we can see of heart failure. This is leading to failure of the heart to deliver oxygen at a rate with the requirements, needing the requirements of the metabolizing tissue. The guidelines, of course, see this as a clinical syndrome that results from structural or functional impairment of ventricular filling. What about the symptoms? You can see the patient having a variety of symptoms, having shortness of breath, difficulty in focusing. He's not focusing at all. He is not able to exercise. He's not able to do any activity, having palpitation, having dry cough, having fatigue. So all of these are symptoms of heart failure. It's an illness that, of course, it consumes very important part of the healthcare resources. It has an impact on morbidity and mortality. It affects the quality of life. So it is really have a burden for economic burden on the country, as well as morbidity, mortality, the quality and life of these patients. So we do need to have drugs that change the natural history of the disease. We have a broad range of therapies, medical therapies, we have devices, we have care strategies, classification. Of course, as you all know, this is dependent upon the ejection fraction, and this is according to, you do it by echo, and you can measure the ejection fraction by different techniques, by echocardiography, and we do have a cutoff value for the ejection fraction. And the cutoff value of here, maybe 40%, which heart failure with reduced ejection fraction, less than 40%. Heart failure with mildly reduced ejection fraction from 40 to 50%, and preserved, of course, if it is more than 50%. If you are asking, what about the difference between the reduced and preserved ejection fraction? Equally, they are the same. We have patients with reduced and preserved ejection fraction in a quiet, equal manner, which is very important. And now we are very concerned with the patients with, of course, the preserved ejection fraction as well. Reduced ejection fraction, this is, of course, this is a patient who's having MI. Definitely, the first cause of heart failure is ischemic heart disease, as we all know. And this patient who's having ischemic heart disease, myocardial infarction, after 6 to 8 weeks, the patient had symptoms with no improvement, and still he's complaining of dyspnea with NIHA class 3. Ejection fraction was 38. What do you think what we will do? What will you do investigations? We look for the pro-NB, this is BNP, the 12 ECG, 12 lead ECG, look for the echo, look for the chest X-ray. Of course, this is really very important. Maybe this is class 1. And you can do, of course, routine blood tests as well. This is the way you should try to look for diagnostic tests for a heart failure patient. Pathophysiology. Of course, we do have pathophysiology. This is very important. It's looking for the myocyte. This is very number one. Looking for the neurohormonal renin-angiotensin system. This is, again, very important, and also at the molecular level. These all will lead to structural changes, to functional changes, and all of them of the patients, definitely after the patient having an acute event, subsequent events contribute to worsening of heart failure. We go to definitely a very miserable patients having problematic changes, structural changes, and you can see that the heart become remodeled. The change in the features of the heart is very important. We are talking about remodeling, and remodeling, the change associated with abnormal neurohormonal regulation, culminating in heart failure with high mortality and morbidity. And this leads to the patient, as I have said, 50% will die within 1 year. Within the 5 years, 50% will die. The interaction between heart failure and diabetes is definitely very high. CKD and heart failure are the first clinical manifestations in type 2 diabetes. And this is really very alarming and very important. We can see that the heart failure is a dominant feature in diabetic patients, along with the CKD patients. And there is a probability of survival, according to heart failure, after the first heart failure is very low. As ever you get an episode of heart failure, you will get very important impact on the mortality and morbidity. Risk factors associated with diabetes and macrovascular disease. We know that the conventional risk factors, as we talked about, is dyslipidemia, hypertension, coagulopathy, again, and there is other diabetes-specific risk factors, as we know, the many reactive oxygen species, many other risk factors. Again, the poor glycemic control in diabetic patients independently is associated with increased heart failure risk. So the glycemic control is really very important. Diabetes increases the risk of heart failure, and we all know that it leads to definitely vascular impact on coronary vasculature, on central and paracrine changes. In aggregation, there is, of course, there is another comorbid conditions. You can see a diabetic, obese, hypertensive patients, and this is what we call the diabetic cardiomyopathy. There is what we call diabetic cardiomyopathy. It's a real very important issue, very specific to diabetic patients. And we can see that there is, if you can do an echo, there is firstly a diastolic dysfunction, and then will be followed by systolic dysfunction. And this is really very important. What are the guidelines for management of this patient? Guidelines say very important that definitely you give ACE inhibitor. When you are talking about diabetes with a heart failure patients, and if you have a CKD patients, you look for the ACE inhibitor. It is definitely recommended. And you ask then beta blocker as well. You can give the MRA, you can give the DAPA, or you can give the sacubitril valsartan as a class 1B level. So there are now in an era of treatment of heart failure patients, we are talking about giving a heart failure patient drugs. You give ACE or ARBs, or you can give beta blocker, and we know the beta blockers allowed for heart failure patients. As we all know, this is the pisprolol, this is the nebivolol, the metoprolol succinate, and maybe the carvedilol. So this is the allowed beta blocker. Don't give beta blockers if the patient is having fluid overload. You should just empty the patients first, and then you can give the beta blocker. The MRA is again a gold standard parameter for treatment of heart failure patients. DAPA is a game changer nowadays, and we are talking about a very important drug that have a preventive issue in these type of patients, and this is really very important. So when we are talking of an algorithm for therapeutic algorithm for class 1 therapy indications for a patient with heart failure with reduced ejection fraction, definitely you will just put the ACE, of course, number 1, or ARBs if there is contraindication to the use of ARBs, and then you look for the beta blockers, the MRA, the DAPA, loop diuretic if the patient is having volume overload. And of course, you should otherwise, if the patient is needed, for example, the ejection fraction, we can give an ICD device therapy with some, you can give other way of doing treatment devices for this type of patients according to what the cardiologist need to say. How much you see diabetes with heart failure? Many patients with heart failure complications, and type 2 diabetes, of course, we do have most of the patients, 25 the patients having systolic and diastolic dysfunction. So this is really very alarming and important. Again, on the other side of the coin, we can see that the hospitalized patient with heart failure, 44% are diabetic. This is the story, or the other end of the story, that they are diabetic. Look for the heart failure in coronary care units, in cardiology department. 44%, about 50% are diabetics. And the risk of heart failure increases with diabetes and pre-diabetes. It is a risk equivalent according to the European Society of Cardiology. So diabetes is definitely an important risk factor for, of course, for heart failure. And ejection fraction, as we have said, the reduced ejection fraction, I have just put 40, the 40 to 50, the mid-range heart failure, the preserved, more than 50, and all are them. The improved heart failure is a new classification which is distinctly defined as symptomatic heart failure with a baseline ejection fraction less than 40, with a 10-point increase from the baseline of the ejection fraction, and the second measurement of ejection fraction more than 40%. So now we are talking about heart failure with reduced ejection fraction, with mid-range ejection fraction, with preserved ejection fraction, and with improved ejection fraction. All these are criteria for. Definitely, we can use a lot of, according to the 2023 guidelines, all of them, we need to give them many drugs, and as we can see, all these patients we should start with ACE inhibitors, and this is the cardiovascular risk categories in type 2 diabetes, as it was witnessed. Most of all, we are talking a diabetic patient. This will be risky patient, or will be high risky patient, and definitely we will have to give many drugs like metformin and SGLT2 inhibitors and other drugs. Primary prevention. We can prevent. Can we prevent heart disease? Yes, we can prevent. We can prevent 86% of heart disease by either by lifestyle or by giving drugs. And very importantly, this, we can treat hypertension. This is prevention. I have said that the book of cardiology, the end result of it is heart failure. So if you treat hypertension, you will be able to prevent heart failure hospitalization. Statins, again, is very important. If you use SGLT2 inhibitors, DAPA, of course, this will, in high-risk patients, this will improve and prevent further complications of heart disease, and this is very important. So we have to use glucose-lowering agents with proven benefits. It is no way to use just glucose-lowering agents with no efficacy or preventive strategy on the heart. So it's just a way to lower the glucose, but to lower the glucose with beneficial effect and preventive effect for the heart, and this is really very important. Definitely SGLT2 inhibitors are game changers who have shown that they will prevent the modeling, and definitely they will be fine. So we can see that the drugs recommended in all patients with heart failure, very important. ACE is recommended for every patient. DAPA, again, is very important, or IMPA, to be given in all patients with heart failure, with diabetes. And of course, as we know, that this is the 2023 expert consensus decision pathway management of heart failure with preserved ejection fraction. No, we're not talking about reduced, but we're talking about preserved ejection fraction, where again, we use the SGLT2 inhibitors. It is nowadays, it is not used only for the reduced ejection fraction, but for the preserved ejection fraction, which accounts for 50% of heart failure patients. Definitely, we do have the game changers of SGLT2. I'm very happy to talk about this group of drugs because, as I've said, this have game changer drugs who have proved to be at the molecular basis to decrease the complications, to have beneficial effects on the heart failure patients. Ramipril, of course, is entitled old as gold, as we know that ACE inhibitor definitely will be old as gold, and we used again to use the ACE inhibitors for having in patients with reduced ejection fraction, and an ACE inhibitor for prevention of heart failure progression. It's used after MI to prevent the progression and to decrease the remodeling of the heart failure patient and reduce the risk of MI and stroke. So I'm very happy to talk about this. Is the AIR study very important about the tritase benefits and mortality reduction, very early and sustained, and this is a very important molecule, as we all know, that proven efficacy, and it showed that in patients with clinical evidence of ongoing heart failure, it definitely have resulted in a reduction of premature deaths for all causes and apparent as early as 30 days of having the cardiac insult. This is the AIR study, and this provides the evidence that administration of the ramipril in patients with clinically defined heart failure after MI results in a survival benefit from the heart disease. The ARNI, of course, and definitely in Paradise MI, and it was shown that the tritase in heart failure patients that protects the heart from hazardous effect and remodeling. It have a prognostic impact on these patients with the better results, which is really very important. And of course, if we are talking about the cost, it's very cost effective as available for everybody. You can give it. So the benefit is very well known. It is number one to be given, and it has a protective effect on the myocardium, definitely according to the deficits as well. that in many studies, that it definitely, it is real that SGLT2 inhibitors are the jack of all horses. It is if you are giving SGLT2 inhibitors with ramipril, it will be very good, and this is the target of the patients. In heart failure, preserved ejection fraction reduced or diabetes, and according to it will decrease the all-cause mortality, and definitely it has a preventive adverse outcome in heart failure patients, and of course it decreases the deaths in heart failure patients. يمكن I don't like to introduce to talk more about these, but definitely if you are going to give the ACE inhibitor plus the DAPA and the SGLT2 inhibitors, definitely both of them will have a combined beneficial effects in diabetic patients, in all patients. And I have to say that's prevention, according to, again, to the imperial preserved meta-analysis, again in the patients with having preserved heart failure with preserved ejection fraction, you can find again that it has a protective issue. It adding therapy is adding life, and DAPA definitely has a clinical benefits in reduced ejection fraction when added to ACE inhibitor, and this is the protocol of our patients. As we can see that healthy lifestyle is very important. عايزة ألخص healthy lifestyle كآخر حاجة في المحاضرة. يمكن الجمعية الأوروبية حطتها لمواصفات الإنسان السليم، بتقول 0-3-5-140-5-3-0 no smoking 3 اخد 3 كيلو يوميا 30 دقيقه 4 ايام في الاسبوع مشي، اخد 5 قطع سلطه او فاكهه يوميا الوان مختلفه، مرتين سمك في الاسبوع، ضغط الدم يكون مظبوط، 5 و3 ارقام دهون بالنظام الاوروبي، وصفر لا للسمنه ولا للسكر. هذه هي معادله البريفنشن. وديفينتلي ثانك يو سانوفي. وانا بقول ان انت if you combine the ramipril along with the SGLT2 inhibitor, it will be a great benefit to diabetic patients. Thank you.